Hi, my name is Dr. Ben Albert. I am a pediatric intensivist with expertise in critical care nutrition and metabolism. This course is just one part in a series of modules on indirect calorimetry brought to you by Channel 1, on-demand nutrition education. This module is the first part in a four-part series. This module is the first part in a four-part series. The focus of this talk will be patient selection and testing criteria in pediatric indirect calorimetry. The objectives of this talk today are listed here, focusing on identifying key patient populations and explaining specific testing criteria necessary to complete an accurate test. As you can see from this simplified schematic on the right, critical illness as a result to an insult, such as trauma, sepsis, surgery, or a burn injury, initiates an adaptive response to stress affecting carbohydrate, lipid, and protein metabolism. Nutrition administration is vital to supporting this process and eventually promoting protein synthesis that is needed for tissue repair and healing. However, the metabolic response to each of these injuries to a particular child is different, and the medical therapy we provide can alter the metabolic balance in unknown ways. Although we use predictive equations to estimate energy expenditure as a rough estimate, we know that these methods are often inaccurate in sick children. Therefore, the measurement of VO2 and VCO2 to calculate the measured resting energy expenditure by the modified Weir equation remains the gold standard in our field. Given limited resources to be able to test all patients in an ICU, it is important to screen and identify high-risk patients that would benefit from indirect calorimetry testing. This includes patients with unexpected weight loss or failure to gain weight during their admission, patients unable to wean from respiratory support, and patients with conditions associated with known hypermetabolism. A comprehensive list is included in the most recent published consensus guidelines on pediatric nutrition therapy as shown here in this table. Patients identified should meet certain clinical criteria for accurate testing with contraindications highlighted in the box below. It's important that measurements achieve what we call steady state, which is defined as 5 consecutive minutes where VO2 and VCO2 has a small coefficient of variation, which we define as less than 10% variation. This ensures the best correlation with a 24-hour resting energy expenditure measurement. A practical standardized approach to implementing an indirect calorimetry practice in your unit requires a multidisciplinary approach, including physicians, dietitians, advanced practice practitioners, the bedside nurse, and also respiratory therapists. The practitioner or the technician completing the test should have a structured pre-measurement checklist to ensure appropriate inclusion criteria and documentation of pre-testing clinical metrics. This includes vital signs, medications, and current nutrition therapy. The technician should also ensure that interruptions in care have been minimized prior to and during testing. Testing usually takes between 15 to 30 minutes from setup, calibration, and testing. As mentioned before, the technician should monitor the variability in measurement to ensure a 5-minute steady state period was achieved before completing testing. After testing is completed, the information can be downloaded and interpreted with the clinical team to assess whether the results make sense with the physiologic state of the patient and how nutrition prescription can be adjusted based on these measurements. Factors that are important to note that can affect accuracy can be divided into several categories, including circuit compatibility issues, timing considerations, and issues with medications and interventions as shown on this particular slide. For instance, a patient with a significant air leak with chest tubes in place would be unable to be tested due to the fact that this is not a closed system for accurate VO2 and VCO2 measurements. In summary, measured resting energy expenditure by indirect calorimetry is a powerful tool to guide nutrition prescription therapy and remains the gold standard. A standardized multidisciplinary approach should be developed to screen and test the most high-risk patients in the ICU. Repeat measurements in children with a prolonged or rapidly changing trajectory can also be retested to assess the metabolic variation through a patient's disease progression. I would like to invite you to watch the other videos in the IC Channel 1 series to learn more from my esteemed colleagues. Thank you very much and have a great day.